thank you for the introduction. بنرحب كل الناس بالمؤتمر التاسع بتاعنا. زي ما احنا شايفين من اول السيشن احنا الناس كلها they are speaking the same language. احنا مش هنشذ برضو عن اللانجوج دي، وان شاء الله باذن الله we are trying to do the planning and the optimization of the patient journey, the pre-operative. We will be concise to hip replacement as an example for the planning and the optimization. So as I mentioned, the lecture is going to be two parts. The first part is going to be the planning. The next part is going to be the optimization. So planning, why? What's the ILO of the planning? To describe the key steps in total hip arthroplasty, explain the templating process and its relevance with regards to the key steps. Recognize the benefits and checklist provides in Skill Labs booklet. So the pre-operative planning includes a plain X-ray. So please, when the patient comes with an MRI, with an CT, you have to do a plain X-ray. This, why? To prevent the component malposition. As we know that we have two components in the hip, the acetabular component and the femoral component, increase the rate of aseptic loosening, increase the rate of the dislocation, bad functional result. If we don't do a plain X-ray and we don't do any templating, we will have such drastic effect. So our goals is to accurately implant the component, the type and the size and the positioning. Avoid problems at the complication and the patient dissatisfaction. So the end results of all our surgery is patient satisfaction. So here, this is the very important figure and very common, as you can see here, and this is being given to the residents coming to our unit by the Arthroplast unit, and Professor Ahmed Abdelali is always emphasizing on templating and doing the measurements. So we have the muscle lever arm, as you can see here, it's these the abductors, and the joint reaction force, range of motion, impingement of the femur over the acetabulum, and the instability. So here we have this figure. You have to copy it. You have to know it, and all the residents who came to our unit, although already they have it. Then we have the plain radiographs. We always stress to do regular and accurate plain radiographs. You have to do a pelvis, a true pelvis that you can see here with a 10 degrees internal rotation of the femur in order to compensate of the femoral neck anteversion. And to do a true lateral or the shoot through lateral or the table through lateral in order to detect any osteophytes. So these are the radiographs that you should do in the hip. That's it. Okay. Then you have to put a marker, especially in the new hospital. There is now the software is not adjusted. So please be sure that this is the left side, this is the right side. We almost all the time we have the flipped X-rays. So take care of that, please. We have to know some important landmarks like the teardrop here. And you have to know the sourcil, the eyebrow, the placement. This is to put the placement of the cup in total hip, the ilioischial line, which is the collar line, or the superior acetabular edge, the sourcil, or the eyebrow, which is this part. And you have to know the reaction forces over the femur or the shaft, and you have to visualize the greater stroke, the lesser stroke, in order to adjust the length and to justify if your patient is lengthened or not post-operatively. Then these are the landmarks, as we can see once again, and you have to see the obturator foramen. This is the true AP. This is the AP that you should get. Don't be hesitant and don't accept that view. You have to see the obturator foramen like that. Okay, then the length. The residents and the fellows who are in our unit, we teach them how to assess the length pre-operatively and post-operatively by this way. And Professor Ahmed Abdelali is always emphasizing at that point. I'm not saying that this doesn't happen, it's the routine work. Okay? Then identify the deformity. If the patient is pre-operatively having a deformity, a DDH or a Perthes disease or a dislocation of the hip, so we have to address it from the beginning in order to choose the proper hardware for that patient. Then templating of the acetabulum, because sometimes the companies, they don't provide us with the proper size of the acetabular cup. And we have to know the inferior edge of the cup should be placed at the teardrop, touch the ilioischial line, and we should do a 45 degrees of inclination and to define the implant size. This is pre-operatively. Don't rely on the company that, oh, we do have all the sizes. We have to template it and to have a pre-operative estimate of our cup size, and the same for the femur. As you can see here, we don't have a lot of option of the femur offset, but usually you should have lots of options in the femur offset, and this is going to be discussed in the intraoperative optimization of the patient. And we have to do the cuts to plan for the cuts. This is a preliminary cut, and this is the regular cut between the greater trunk and the lesser trunk, 1 finger width above that. And then you should also know the medullary canal size in order to place the urostem. So after we did the templating, we did our x-rays, the patient, we should be optimized. I'm not going to say lots of things because we've been covered in the previous talks by lots of important issues. But for example, diabetes. The patient, you always say that the patient, the uncontrolled diabetes, and we will have in the next session a very fruitful and very important lecture by Dr. Wala that's gonna discuss the diabetes and how to see the diabetes. So usually our patient is an elective surgery. It's not a trauma surgery like the previous talks. It's an elective. So if you have a hemoglobin A1C less than 7, or this is the ideal for sure, but up to 8 you can operate. Okay. The immune system comprised, they have lots of diseases like the rheumatoid arthritis, you have the seronegative, the lupus. The patients are on steroids or the DMARDs, the modified anti-rheumatic drugs, so they don't increase the risk of infection. Rheumatoid patients, we have lots of patients that are going for total hip or total knee for which they have a previous long history of rheumatoid arthritis. So this is a very busy slide. As you can see here, this is you can copy it, please, or can take a photo shot for that. These are the drugs that were been taken with the patient with the immunocompromised or with the DMARDs, and you can say that there is some patient they can continue it. You shouldn't stop it. Lots of the DMARDs are safe. You can continue with it. Steroids, as unexpected, the steroids, you don't stop the steroids. On the other hand, you can give a stress dose. You should adjust that. You should consult endocrinologist, whatever the disease, or you can consult a chest. If the patient is on a chronic chest disease or on a chronic steroid, you should have these proper doses of stress doses of steroids. So please don't stop steroids. This is my message. Other conditions like post-transplantation patient, Dr. Radwa was mentioning that it's a very important. You should note, by the way, the chronic liver patient and cirrhotic patient, renal failure that was mentioned, HIV, although it's not too much in our community, but we should routinely screen the patient for the HIV and Hep C and Hep B. Now it's routine in all our arthroplasty patients. Narcotics and addicts, this is a very important issue now rising up in our community. The patient who is on narcotic post-operative pain is gonna be killing is gonna be a big issue. So if the patient is taking narcotics, so don't lower the dose. So in reality, he should take it. Okay. So the patient taking intravenous drugs, they are having higher risk of infection. So take care of that. Obesity, you shouldn't operate patient with a BMI more than 40, and previously, they say that we always advise the patient to do bariatric surgery and come back again after he lost or she lost her weight. But nowadays, we do the surgery before the bariatric because the bariatric surgeries now, they decrease the immunity of the patient. So it's still a debatable issue. The cardiovascular disease, I'm not going to pass through it because Dr. Ahmed Ali Ubaidullah was mentioning. So if you have the patient with a stable angina, the valvular disease, hypertension, and this is not going to be our fields. anticoagulation, the thrombo team, you should have a thrombo team with you and with the vascular surgeon, with the hematologist, and this would be covered by Professor Muhammad Mahran and Dr. Maha in the second session. We should be alert about that. You shouldn't put the doses for the anticoagulants or put the doses for the patient who's on anticoagulant by yourself. It's according to the BMI, and you should consult the thrombo team with the hematologist and vascular surgeons. So these are the anticoagulants. Some of them the oral ones, the new generation, you don't stop them, and even if they are from pre-operative, you can continue post-operative safely. But usually we put the intravenous ones, and these ones, and the low molecular weight heparin, this is the Clexane, as we all know. We just give the patient pre-operatively and stop for 12 hours, then we recontinue. This is our protocol in our unit. Malnutrition is a very important issue, and this was covered also was by Dr. Muhammad Anwar. And you should also optimize the patient if he or she is underweight or immunocompromised, or the nutrition is something is very important, and you should take care of these counts. And alcohol, thanks God, it's not in our community that much, but if the patient is alcoholic, or she or he, in Canada, we had lots of problems with these patients in high risk of infection, high risk of dislocation and falls after the implant, and periprosthetic fractures. Anemia, and also going to be discussed by Dr. Maha Mustafa in the second session, and hematology consultation, as I was saying. Smoking also is one of the important issues, and the patient should stop smoking 1 month before the arthroplasty, as we were mentioning by Dr. Muhammad Anwar, and you should give the patient the modality in order to stop or do cessation of smoking. At the end, you should be honest with the patient, because the expectation of the patient is by you. So don't just tell the patient you're going to be magic, you're going to be having a new hip, you're going to be playing football or whatever. You should do some restriction, because the patient expectation should meet the surgery, shouldn't be beyond the surgery. So the take-home message for planning, it's important, mandatory, and you should determine the implant size before, and you should correctly restore the biomechanics of the hip regarding with the safety and optimization of the patient. So the patient safety is not an accident, it's always planned. Successful surgery depends on appropriate planning. Pre-operative optimization is the first key to the patient safety and satisfaction. Thank you so much.